Good morning, everyone. My name is Derek Coy, and I am a senior program officer here at the New York Health Foundation. I'd love to start off by thanking you all for joining us today for this heavy, though incredibly important conversation on suicide prevention in the veteran community. As a former sergeant in the United States Marine Corps and veteran of the Iraq War, this is a topic that's very near and dear to my heart, as is the case for most of us that have served in the armed forces due to the prevalence of this issue. So I truly appreciate you being here today. I'm also very grateful to have three brilliant and illustrious guests I have had the pleasure of working with over the past few years on this topic. So I'm very excited to be in conversation with them here shortly. Before we kick things off, I'm at the Foundation's headquarters in New York City. So it's with honor and gratitude that I acknowledge the land itself and the Lenape people who have stewarded it for countless generations before being displaced. Also, considering the gravity of this topic, I encourage folks to be kind to themselves and take whatever self-care steps are needed during and after this event in case you find any part of this discussion triggering. And if you or a loved one is experiencing thoughts of suicide, please know that you can dial 988 at any time to be connected with the National Suicide and Crisis Lifeline. It's an excellent resource that I've personally used myself. And just a reminder, there's never any shame in reaching out for help if you need it. Lastly, before we jump into the conversation, I would like to start off with a few housekeeping notes for our hearing impaired attendees like me or anyone else in need of live stream captioning. You can click on the closed caption icon at the bottom of your Zoom screen and select the show subtitles and or full transcript option there. In addition to our excellent guest, we have a great audience joining us today, so feel free to send comments and questions into the chat box and share any contact info or resources you'd like there as well. We'd love to hear from you, and I'll try to sneak in any questions that we can. And just a heads up, this webinar is being recorded, so we'll be sure to send out an event recap email with a link to the video that will be sent to everyone in the next few days, so be sure to keep an eye out for that. And finally, without further ado, I'm excited to kick off this conversation. You have their info, but all three of our prolific guests wear numerous hats, serve in multiple roles, and have been invaluable resources to myself and so many others on the important topic of veteran suicide. So Dr. Gamble, Dr. Goodman, Dr. Kasanoff, I truly appreciate you all joining us this morning. And would love to start things off with a level setting question for you, Stephanie, if I may. In the comic book world, writers always assume any comic is someone's first comic. So they always include some background to catch folks up in every issue. And I wanted to see if we could do something similar. But before we home in on veteran suicide in particular and get into the weeds with that discussion, for folks that might be new to this topic, I was wondering if you could tell us what we currently know about suicide overall nationwide, and what have we seen in that regard over the last few years?
Thank you, Derek. Good morning, everyone. It's a privilege to be a part of this panel today. I'd be happy to provide some level setting information. I wish I had better news to share, but the trends in the US in general and for veterans specifically are moving in the wrong direction. Today, we're going to talk probably about data and numbers and counts and rates. And all of those are critically important to understand the magnitude of the problem of suicide in the US. But I think it's also critically important to remember that each of those numbers, each of those data points represent a life that was cut short. They represent a person who was part of a family and part of a community. And to save lives and prevent suicide, it's going to take all of us to work together. And it's really inspiring and heartwarming to see so many people joining the panel and the call today. And the contributions and the generous support from the New York Health Foundation, I think, are critical to certainly our success in New York in improving lives. We certainly have a lot of work to do to do together moving forward. So let's just jump into kind of the task at hand. According to the CDC data from 2021, which really represents the latest data that have been cleaned. I know there were some 2022 data that were released provisionally, but if we focus on the 2021 data, that will allow us to kind of think about how the general population data can compare to the veteran numbers. According to those 2021 data, there was an increase of 36% in the suicide rate from 2000 to 2021. In 2021 alone, over 48,000 people died by suicide. And some groups have higher rates of suicide than others. These rates can vary across race, ethnicity, sex, age, and other factors. By race and ethnicity, we see that the highest rates are in non-Hispanic American Indian and Alaskan Native people, followed by non-Hispanic white people. The suicide rate among males is 4 times that of females. In age, when we look at the age, across all ages, suicide is a leading cause of death. It's the 11th leading cause of death in 2021. But if we drill down and look at the ages a little bit more, with a little bit more granularity, we see that the highest suicide rate in the general population occurs in those 85 and older. But there's an alarming trend among young people that's starting to emerge. Particularly in the 25 to 34-year-old age group. Keep in mind, this is the general population numbers, the level setting that you talked about. But in that age group, suicide was the second leading cause of death in 2021. Another kind of important benchmark, I think, for all of us to kind of keep in mind, especially for this conversation, is that firearms were the most common method of suicide. Over half, 55% in the general population, occurred by firearm, followed by suffocation and poisoning. And another group with higher rates of suicide are veterans.
Dr. Gamble, I really appreciate that. It's really tough to hear, the gravity of this, but the context really helps when we're looking at solutions and really understanding where we can put our resources behind, and knowing that we have you on this larger team is really inspiring. So we appreciate that level setting and you joining us today. Marianne, to turn it over to you, I think we've known, veterans have been disproportionately impacted by suicide for a while, but I believe the first comprehensive national report was put out by the Department of Veterans Affairs in 2016, which was looking at 2014 numbers. And despite it becoming the gold standard for data on the topic, there were historically issues surrounding things like, who we classify as a veteran compared to, active duty or not, methods, and how we conveyed this information. There was the big 22 a day that was kind of, a catchphrase for the longest. But now that we have, a better understanding of the larger topic of suicide nationwide, thanks to Stephanie, maybe now we can look at what we currently know about the topic of veteran suicide based off the latest data, any trends that we've seen there.
Yeah, thank you so much. Stephanie, great overview. As Derek mentioned, there is a VA suicide report that comes out every year. The last one just came out in November, but the previous one in 2022, using 2021 data, noticed that there was a dip in suicide rates, which was great news. But this dip disappeared this past year in the 2023 VA suicide report. And that probably has a lot to do with the pandemic. But we know in this last 2023 report, using data from 2021, it takes 2 years for that data to be acclimated and synthesized. 6,392 veterans did die by suicide, and that was an increase of 114 suicides from the year before. And when we look at age and sex adjusted rates among veterans, the rate increased by over 11%. And this was 72% greater than that of non-veteran adults. So again, the suicide risk in veterans is so much higher than in civilians. We know that of those deaths, 6,042 of those deaths were from veteran men, and 350 of those deaths were from veteran women. The suicide rate, unadjusted suicide rate for men was 35.9, which was 3.5% higher. But listen to this number for women. It was 17.5, which was 23% higher than in 2020. So again, we're concerned about veteran women in particular. Because of the pandemic, there were issues with financial strain, housing instability, and increased anxiety and depression levels. There were barriers to obtaining health care. And also there was a lot of political violence. And so there was increased firearm availability and purchasing of firearms. We'll be talking much more about that as this um, meeting goes on. And this all was associated with heightened suicide risk. Particular subgroups that were worried about veterans, similar to what Stephanie was saying about American Indian and Alaska Native veteran individuals, also see that in the veteran population. Their rates of suicide are much higher. I mentioned we're concerned about veteran women, but also veterans who are homeless and veterans who receive justice, who are in the justice system, are also a concern. And I think I'll stop there.
No, thank you so much. I really appreciate that. And again, it's a tough topic to discuss, but knowing that we have this kind of granularity in the data, we have an understanding of, who's being disproportionately impacted. I think that, gives us a little bit of hope, in regards to what we can do about this, very, very complex issue. So Dr. Kazanov, could you fill us in on what the latest data say about how this issue has impacted veterans in New York State in particular, considering we're following the similar theme, knowing that the country is not a monolith, nor is the veteran community. So we are seeing, wide variations in how this issue impacts veterans in different regions and states. So we'd love to hear more on that from you.
Yeah, thanks so much for having me, and thank you to Stephanie and Marianne for their comments and context for these numbers as well. So, as Stephanie shared, the news on a national level was not great this year. Things are looking a little bit better for New York, at least compared to the national average, and so. When you look at New York specifically, we can see that the suicide rate for veterans has not increased. It's been relatively stable over the past 10 years. So unlike nationally, things have pretty much stayed the same here in New York. It's important to note that there are two trends. So one is that in New York, the rate of suicides in general and among veterans as well is actually significantly lower than it is across the nation. So that, so in New York specifically, there are about 20 deaths per 100K individuals, whereas that's about 34 deaths per 100K individuals. And this is among veterans across the nation. So that's a pretty big difference. But in New York, we see this disparity among veterans versus non-veterans as well, where veterans have about twice the rate of suicide than civilians do in New York. And it's important to mention that some of that difference can be accounted for by demographic factors. And so among veterans, there are a higher percentage of men and also a higher percentage of younger individuals, which are both factors that increase risk for suicide, but that doesn't explain everything that we're seeing. So there's something about veteran status as well that's contributing to these higher rates. And then Marianne mentioned firearms. So just in terms of like New York and firearms, we saw a little bit of an increase in the rate of suicides by firearms in the nation over the past year. It went from about 71 to 72%, whereas that decreased a bit in New York. And so it went from about 57% of suicide deaths involving a firearm to about 50% from 2020 to 2021. And so the hope is that that's a sustained trend that keeps, moving in the right direction over time.
Yeah, absolutely. Thank you so much for that. Hopefully for folks in the audience, we have a good overview of kind of the larger issue of suicide nationwide, and certainly honing in on, veteran suicide nationwide. And now, of course, a large focus of our work is how this impacts veterans in New York. So really appreciate that. And of course, all three of you, the work that you all do. I mentioned before that our three guests have been, an invaluable resource to myself over the past few years. And that's mainly due to us getting connected via the governor's challenge to prevent suicide. Something I've been very honored to take part in, and again, work with brilliant folks like our guests today. So Stephanie, back to you for the folks that might not be hip to the work of the governor's challenge. Can you give us a quick overview of what that is? And I think you kind of alluded to this, and we've already kind of danced around it, but also maybe give us a better understanding of why we chose to focus on lethal means safety as one of the 3 approaches that the challenge would take?
Sure. I love the Governor's Challenge program. I'd be thrilled to share a little bit more about it, but also would welcome Dr. Goodwin's perspective as well. She's been a vital member of the team, and now Gabby. But the Governor's Challenge grew out of a partnership between SAMHSA and the Department of Veterans Affairs to come up with more kind of specific state level and even city level. There's a mayoral component as well. Wasn't involved in the mayor's challenge, but the governor's challenge has now spread to 54 states and territories. And the challenge is around preventing suicide among service members, veterans, and their families. And the objectives of the challenge are for states who are committed to the program to convene a state or territory interagency team that's made up of military and civilian team members to come up with an implementation plan to prevent suicide among service members, veterans, and their families. So it's really a whole of nation approach to bring together people, the right people from a variety of different sectors who can engage others, who can really understand the issues of suicide prevention that are important for the local communities, local counties, and the states themselves. So really, it's about increasing knowledge about the challenges that individual states might have, but also benefiting from the collective knowledge of challenges that might be across different states. And there's a ton of technical support that's built into these programs, where there are implementation academies, policy related academies to really set states up for success in figuring out what are going to be the localized solutions for those states in helping to prevent suicide. And the wrapped around all of this support are 3 different priority areas that SAMHSA and the Department of Veterans Affairs determined would really move the needle on suicide prevention. And those 3 priority areas are identifying service members, veterans and their families, and screening for suicide risk. That's priority area 1. The second priority area was on promoting connectedness and really enhancing care transitions in the community, particularly after crisis hospitalization or crisis mobilization. And then the third priority area, given what we know on the general level, or the general population about the importance of firearms in suicide and among veterans specifically, the third priority area was around increasing lethal means safety and safety planning. So the states are left to come up with individualized solutions, but those are the 3 priority areas that provide that framework. And it's a 2-year program that includes a variety of different policy and implementation academies, lots of support from brilliant people. We've got RAND involved, helping states come up with measurement solutions and tracking success. And then the SAMHSA TA Center is super helpful all along the way.
Thank you so much for that. Again, it's really been an honor to be part of this group and hear what other folks are doing, really sharing resources. And to that note, just thanks everyone in the chats, throwing out resources and some questions. Joe Bello, friend of the foundation, we're going to get to some of those here in a bit. But now that we know, a bit more about the challenge and then, the approaches participants would take and why, Marianne, I'm wondering if you wouldn't mind filling us in on kind of what our first action items were, if you will, in response to this work, specifically the counseling on lethal means access or COM projects that came from these efforts.
Yeah, so we were part of the lethal means safety subgroup, and we spent a lot of time trying to figure out the best way to address this topic in New York. And the idea of some type of programming around lethal means safety, we debated whether it should be clinicians, although there are several programs already targeted to clinicians. we arrived at the idea of actually involving family members in lethal means safety. And so we didn't know much about this, so we actually decided to talk to family members. We interviewed about 20-ish family members, families who lived with a veteran who had had a serious suicide using firearms, families who lost a veteran to a suicide using firearms, and family members who just lived with a veteran who had firearms in the home. And we wanted to understand what education did they need, what resources, what was the best way to reach them. And what they told us was very, very interesting. They did not want PowerPoints. They did not want presentations. They didn't want a lot of data. They actually wanted stories. They wanted to know that they weren't alone with these types of situations. And so what we decided to do was to build a website. It's called worriedaboutaveteran.org. And in that website, we actually have video vignettes of family members facing various situations about firearms, including how to detect suicide risk in a loved one, how to start a conversation about firearm safety, how to ask for help, and how to navigate some of the safety storage options that are available. On this website are these sort of stories. They teach through the stories along then with other information that accompanies the vignettes. There are also some clinician, as a veteran and firearm owner, 3 videos about speaking from his vantage point, the best way to help families. As well as there's a wonderful resource that started out for New York State only, and then we expanded it to statewide across the nation. And that's all the firearm transfer laws for every state. And this turns out to be very important because if you want to have the firearms out of the house, we need to know who can hold them. And so this particular map, you just press on a state and the laws come up, is a fantastic resource. And we really want this website, again, worriedaboutaveteran.org. This was funded by the New York Health Foundation. We're so appreciative, but it's a resource out there for family members, for clinicians to have family members to use it. And we just want to get the word out. It's a fabulous resource. We've had a subsequent study, and I think Gabby's going to be talking about that, developing in-person trainings as well as virtual trainings that continue and build upon the website. But I'll leave that for Gabby to say more.
Well, thank you so much for that, Marianne. I think, a few things that you touched on there that they're really important to, us at the foundation. We make it a point to not talk about populations. We talk with populations. So the idea that we're bringing in family members and asking them directly, what is it that we can help with as opposed to here's what we think should be happening. I love seeing that really involving the community. I think any veteran or anyone who works in the veteran space knows how important families are. So really seeing how that's responsive to, the needs and desires of these folks that are, accessing these resources is super important to us, and really appreciate the work you've done on that. Also, the idea of like the trusted messenger, who do you want to hear this from and why? Who is really going to move the needle on making sure that we're talking about, what can be done? I think there's a misconception that all vets are like super pro Second Amendment, don't even talk about guns and I've found, personally in my experience, would love to hear, if anyone, feels the same. I think vets, it's ingrained in us firearm safety, and we understand the severity of the suicide problem within our community. And oftentimes vets are, there's probably no better person than vets and family members to say, hey, I'm concerned. Here's what we can do about this collectively, as opposed to here's what you need to do. So it's really been an honor to work with you all on this and support the work that you all do. And not only has it been great to work with you on this incredibly important topic, just historically, but also an honor to continue supporting and expanding this great work. So Gabby, as Marianne mentioned, I'd love to see if you could fill our guests in on what you've been up to recently, kind of building on this work. Any lessons learned or takeaways from these projects in the past few years?
Yeah, definitely. It's been, like Derek said, so illuminating to talk with veterans and their family members about what they need and services that can help them during these difficult times. And so, building off of the success of the Worried About a Veteran website that Dr. Goodman just described, we also heard from family members that there was a real need for community building around this topic, getting to know others in similar situations, and having some hands-on practice talking about these really challenging topics. And so the second phase of this project, we worked to develop a workshop that is co-facilitated by suicide prevention coalition leaders across New York State and firearm expert facilitators that relayed a lot of the same information, but in a more hands-on fashion. So both of the facilitators working together talked about just basic information about firearms for family members and loved ones, options for secure storage, relevant laws, as Dr. Goodman talked about. And also a really big part of the workshop is just how to talk to loved ones about this topic, given the challenges in doing so, and the need for practicing these sorts of conversations. And so over the summer, the workshop was piloted together with 5 counties across New York State, each by a local suicide prevention coalition leader and firearm safety expert. And then recently in October, we held a Train the Presenter event to further disseminate it across New York State, and are now working on a project to get the workshop to some of the audiences that were more difficult to reach. So working really closely with community organizations, veteran serving organizations, members of the firearm community and faith communities to potentially adapt the workshop for their needs, and also get it out there so that individuals who could benefit from it are able to come into contact with it. And then one other thing we're doing is, as you may know, this workshop is not the only resource on lethal means safety or the relationship between firearms and suicide and secure storage. And so part of what we're doing now is working to figure out what all the resources are and to develop a toolkit for communities to be able to select which of these educational opportunities might be best for them and how to get the information to their community members. And so we're excited to keep moving this project forward and disseminating it really to whoever we can who might benefit across New York State. In terms of takeaways, one is just that it's been like a real honor to work on this and to have the resources to be able to work really closely with community members. The most exciting part for me was just the enthusiasm and commitment that we saw both from individuals in the suicide prevention community, working really hard, mostly volunteering in coalitions across the different counties in New York State, and also the firearm experts that we worked with from the beginning to build the workshop. And so these are a lot of veterans, gun shop owners, firearm trainers, firearm educators, people in firearm advocacy, who were really enthusiastic about working with us on this problem of suicide and how to increase suicide prevention resources and education in the community. And so, just as Derek mentioned, we know that information about firearms comes best from those with expertise in the area, as you would imagine, especially, veterans hearing from veterans, from peers who are involved in the same activities as they are and sort of have the same background and interests. And so that was a really nice and unique part of this project, just being able to build these resources from the ground up with different groups of individuals who are super committed to figuring out what would work best for their communities.
Yeah, thank you so much for that. And also just shout out Mike Matthews here in Staten Island, brings up a good point. We're talking about firearms, and I've been so guilty of this, interchanging firearms and lethal means. which lethal means it could be suffocation, overdose, you name it. And in New York City, that's very different. So I think that really just speaks to how there is not a monolithic, community or area, and really speaks to the importance of bringing together a lot of different folks, like the great folks that are here joining us today, to really figure out what's the best approach, on a very, local level. Also, again, Gabby, I just can't thank you all enough, because I'm a veteran, I'm a Marine, I come from a family of Marines, I grew up in Texas. So firearms, it's so ubiquitous, it's such a common thing, part of my culture historically, and it's still super awkward. How do I have this conversation? What do I do? Veteran to veteran, you name it, and the resources you all have provided, and also just the help that you all have given me over the years, is just really, really appreciated. And I love to see this moving forward and really helping other folks out there. We started with a kind of a macro view on the topic of veteran suicide, and we zoomed in quite a bit, which I'd like to do more with the focus on one subpopulation that has been disproportionately affected by the suicide epidemic, which is recently transitioning veterans. Marianne, I recently revisited a translated copy of, pardon my literal French, Le Suicide by influential French sociologist Emile Durkheim. And of the many important takeaways from that work, I'd like to harp on his argument that suicide primarily results from a lack of integration of the individual into society. Now, this work is, published into the 19th century, so it's, dated in some ways, but also very revealing. But I'm wondering if that argument still holds true, especially for transitioning veterans, and if you could fill us in on unique challenges veterans leaving active duty face in regard to suicide and risk.
Yeah, thanks, Derek. I really appreciate that. Absolutely. We know that 200,000 individuals leave the military every year, and they are confronted with a variety of different psychosocial stressors, adjustment challenges, disruptions in their social support, financial strains, changes in access to healthcare and mental health care. They come back, sometimes their family life has changed, they've left a very structured environment, and all of a sudden they have to find a job and maybe a place to live. And that adjustment has been very, very challenging. This is a subgroup of veterans where the suicide rate is going up markedly. And Stephanie talked about the young people. We think that young people, that cohort, is actually the transitioning veterans themselves that are making up so much of that suicide rate increase. We know that the first year after leaving the military, that's double the rate of suicides than when they're during active duty, as well as in non-veterans, and that rate stays elevated for about 6 years after the transition. So this is a very, very high risk time. We know that veterans who were discharged dishonorably have a higher suicide rate than those that had an honorable discharge. And we know that those that had some type of suicidal ideation or symptoms in the military obviously are going to be at higher risk when they're discharged. The problem is that many of these individuals don't seek care when they leave the military. There's something called a deadly gap from when they leave the military till they actually establish care later on. And that is a very, very high risk time. We know that veterans from the Marine Corps and the Army have a higher suicide rate than the Air Force. We know that those that are leaving the military who are younger do worse than those that are older, as well as shorter enlistments have a higher suicide rate than those that have had a longer enlistment. There's a lot of attention being paid right now in the VA to this population. I want to just kind of give a shout out to Dr. Joe Geraci, who works at our center, who himself is a transitioning veteran and Army Ranger, is developing programming specifically for these individuals who are transitioning, helping them seek care right at that junction when they leave, as well as identifying those at a higher suicide risk with a suicide screen. So we think we're going to do a better job patching up that gap and really help with that reintegration that you referred to, Derek, that I think is so key. And I think Durkheim had it right.
Thank you. Thank you so much, Dr. Goodman. Denise brings up a good point now, to be open to other resources, which I completely agree. And I think to Gabby's point, we really are looking at, collectively what else is out there that we can share. Of course, I'm the president of the Marianne, Stephanie, and Gabby fan club. So like, I really love what's happening here. But yeah, we know that, the comm trainings or what we're doing here specifically can't, cover everything. So it really is important to see what else is out there. Carlos put a question. I think I might have misspoke. Of course, lethal means suicide is lethal. What I was saying is when I think of lethal means, I think exclusively of firearms, which it could be anything else. So hopefully that answered that question there. Sorry if I misspoke. But keeping with the focus on particular subpopulations, we know that women have fought for the nation since the Revolutionary War. But since the cap limiting female participation in the military was lifted in 1973, the number of women that have served has risen substantially, and women are now and have been for quite a bit the fastest growing demographic in the veteran community. And we also know that, VA has put out some great work, and so is the Center for a New American Security, highlighting that, women vets skew younger than men. They're more racially and ethnically diverse and have other characteristics that vary from the larger vet community. So, Gabby, I was wondering if you wouldn't mind filling us in on other ways, this population varies compared to the larger veteran population, especially in regards to suicide and risk.
Sure. Thank you for that question. So, Dr. Goodman mentioned a little while ago just the big increase that we saw in rates of suicide among women veterans, especially when compared to male veterans over the past year. So, there's been a 24% increase in the suicide rate for women veterans over the past year. And as you just mentioned, this population skews younger. And so that's a particularly high risk for those younger veterans under 35, many of whom, as Dr. Goodman mentioned, are transitioning out of the military. And one big difference among veteran women compared to non-veteran women is the use of firearms in suicide. And so about 50% of suicides among veteran women involve firearms compared to about 35% of non-veteran women. And so it's likely that part of the difference between those two groups is related to the use of firearms. We know that firearms are the most fatal means of attempting suicide. And so the more people who are attempting suicide with a firearm, the more unfortunately who die by suicide. And so as Dr. Goodman said, the transitioning veterans and the women veterans, and then as Dr. Gamble mentioned, individuals from the Alaska Native and American Indian community, those are kind of the top demographic groups that have been highlighted as being kind of at increased risk at the moment.
Gotcha. Thank you so much for that overview. And certainly, to our panelists, but, anyone of the guests, any of our guests here, something we've had, trouble with is we know that, fortunately, the number of women veterans that die by suicide in New York is below 10. So we don't really get that granular information. And it would be really revealing if it's 9 or 1, if, 9 are using firearms or only 1 is. And we've had trouble kind of figuring that out. So if there's anyone else out there, that maybe has a better insight on that, would love to, hear more. Stephanie, I'd like to widen the aperture a bit and kind of go back to the topic of data, since it's what drives, how we discuss this topic and what we put our resources behind. The numbers as is, they're already alarming. And you all have done a great job of explaining the severity of this issue. But I know there are a lot of issues surrounding, how we classify what was or wasn't a suicide. And the other epidemic we've been facing, that of drug overdose, seems to muddy the water a bit between whether something was an accidental overdose versus an intentional suicide. And when you factor in things like passive suicide, something I was guilty of in the service, just kind of reckless living, where you kind of don't care if you live or die, you maybe drink a lot, you drive fast, you name it. And it leads to an accidental, or premature death. I'm wondering, and I would love to know if these instances are being factored into the larger discussion of veteran suicide, whether they're extraneous and distracting, or is it something we need to have a better understanding of before we can draw any larger conclusions?
Excellent question. I think we could spend another hour or perhaps 3 hours talking about that very question. I'll answer the question just from my perspective, not speaking on behalf of the Department of Veterans Affairs or the Center of Excellence, but there's a term called self-injurious mortality that is, or deaths of despair that I think is becoming more common in the literature, in the field. Ian Rocket, who is at West Virginia University, he's professor emeritus now. He's done a lot of work with Dr. Eric Kane around this concept of self-injurious mortality. And in the epidemiological work that Dr. Rocket and Dr. Kane have done, they've actually, I don't think it's muddying the waters. I think in some respects it's broadening the scope of premature death in America. And if we wanted to talk about kind of being alarmed by trends in numbers, if we include all of the deaths, these premature deaths that are occurring because of accidental overdose or intentional overdose, it's easier for medical examiners and coroners to determine that a death is a suicide if a firearm is involved. But if there are a variety of other factors, or if there's ambiguity about intent, the way that manners of death are determined in the U.S., things can be accidental or they can be natural or unnatural. And then among the unnatural deaths, you could have homicide, suicide, accidental, undetermined, and pending. And so many deaths can get classified as something other than suicide if intent isn't obvious from the start. And I think the solutions that we're talking about, the solutions that the Health Foundation is interested in, if we're talking about ways for people to enhance their lives, things around finances, around some of these social determinants of health, about relationship building, these are upstream interventions that are likely to have an impact not just on suicide, but on some of these other adverse outcomes as well. So I think classification and the way in which in the United States, there's not one standard way. We have coroners, we have medical examiners, the data, even determinations about veteran status are made by different people. Sometimes it's the funeral director, sometimes not. I think a lot of work can be done, but it's also, I think, important for us not to lose sight of the fact that if we work really hard together to improve people's lives, then hopefully we can avoid these premature deaths, regardless if they're classified as an overdose or a suicide. I think the bottom line is that these are deaths that did not need to happen.
Absolutely. There are so many good points in there, and I really appreciate that response. And I think that really does really, paint a more vivid picture of what we're dealing with here and how best we can, approach these issues. Mary Ann, I'd like to turn it back to you. We've been focusing on this work at the Governor's Challenge. Of course, you all have been doing this much longer and have a lot of insight. You've seen what we've done in New York, but again, we could look at the resources that folks are sharing here in the chat box and others that we know about. We're very lucky that in some ways that New York state policies, are ahead of a lot of other states. But I'm wondering, is there anything else from other states that you've seen that you would like to replicate here in New York, or maybe just in general, more policy or laws that you think would help address the issue of veteran suicide in New York?
So this is not the data question, right? This is more policy.
Oh, yes.
Related?
Yeah.
I think that we've seen a lot in the chat about that there's rural areas, and there were some issues about cities and urban areas where there is stricter firearm laws. So we don't see quite the firearm suicide rates in New York City. We've seen lots of commentary about that. I do think that one of the things that New York does well is the firearm laws and transfer laws. And I think that makes a tremendous difference in suicide rates. And as Gabby was talking about New York having lower suicide rates, I'm in large part due to the firearm access. Now, this is a political discussion. I don't necessarily want to go there, but I do think that having firearm laws that limit access can and reduce suicide. And we want to make sure that those that are at highest risk, we can protect them, either with their families, like some of the work that we're doing with the CALM work. And I think that does vary across the United States. And you can actually see that, again, as I mentioned, on the website, the worriedaboutaveteran.org. Those laws are actually listed there for everybody.
Gotcha. Thank you so much for that. Gabby, just like to reference an article I read last month in Military Times. It mentioned that exchanges on Army and Air Force bases would limit sales of alcohol in an attempt to prevent suicide, which stemmed from a DoD report focusing on suicide prevention. It also cited research showing of suicides in the American public where toxicology was available. About 1 in 3 people were acutely intoxicated at their death. And I know from personal experience during my time in the service, we were very much taught to self-medicate and rely on alcohol in particular, in lieu of healthy ways to deal with stress, grief, trauma, and definitely, that stayed with me far too long. And I know a lot of other vets deal with something similar. Can you speak to the importance, role or prevalence of alcohol and other drugs in regard to the topic of suicide prevention in the veteran community?
Yeah, thank you for bringing this up. In my opinion or sense of things, it feels like we don't talk about this enough, the connection between substance use, so alcohol or drug use, and suicide. This is a particular concern among veterans, but really among everyone. We know that substance use makes a huge difference in terms of increasing risk for suicide. And then when we think about means in particular, as Dr. Gamble mentioned, there are like the possibility of overdose from drugs that are available. And then also the mix, as everyone knows, between firearms and alcohol or firearms and other substances is like not a good one. And, the opiate epidemic has been raging the last few years, and there is rising opiate use, but also rising stimulant use that has become a real issue among veterans and among the community at large. And so I'm really glad to see this issue getting more attention. And I think it would be great if we put some of the suicide prevention resources that we have that are available kind of in settings where they might be better accessed by individuals who are using substances. So in substance use treatment settings and like harm reduction programs, distributing firearm locking devices, things like that, to really like integrate the two different sort of areas that people are working on in terms of increasing access to care and reducing suicide.
Gotcha. Yeah, and our friend Hugo Lentz at Rally Point, asked, is the theory that New York's more restrictive gun laws contribute to lower suicide rates among veterans, and do we think those laws impact civilian suicide? And I'd like to point out Dr. Craig Bryan. He has a great book called Rethinking Suicide. I believe he's at the University of Ohio State. Ooh, that's probably, if I said one or the other, that's probably not good if I said it wrong. But he mentions how the effects of state laws and policies designed to reduce access to firearms is surprisingly strong, and states with things like background checks and other restrictions have suicide rates between 25 and 40% lower than those without. And also our friends at RAND, Dr. Carrie Farmer, Dr. Rajiv Ramchan, just also brilliant on this topic, among other things, and a great resource for us. I believe they have some information coming out on this soon. So you should always be checking out what they're doing. But on that topic in particular, keep an eye out for some more information on that. One thing, Stephanie, I wonder, because again, I think part of, when we're talking about firearms and suicide, it's just a tough conversation. Like, it's just literally, am I saying the right thing? If I say this, will it turn into something worse? So I'm wondering, are there things, phrases, terminology that we should avoid using regarding suicide? Or is this more of a, hey, you trust this person, they're trying, to get the message across, so it's more important just to have the conversation? Could you kind of tell us a little bit more about that, or maybe provide a little guidance on what we should or shouldn't do?
That's a great question, Derek. I think I would say both and. First off, I would say folks need to be reassured that they don't have to be an expert in mental health or in in nuanced conversation to express concern. If you have a veteran or someone in your life that you're concerned about, you've noticed changes in their behavior, maybe an increase in alcohol or drug use, or just erratic increase in risky behaviors, convey that concern. If we're if you're in if you're in the profession of suicide prevention, there is preferred language. Deaths by suicide or suicide is typically used. We're getting away from using other, kind of older phrases such as commit suicide. You want to avoid complete suicide. Folks don't use completing suicide because it conveys that you've actually accomplished something. So deaths by suicide or suicide is usually the preferred language when talking about deaths by suicide. Usually in the firearms space, I think, and you made this point earlier, Derek, that the messenger is important, and having the language to not convey that we're talking about means restriction instead of secure storage. And I think being respectful that veterans and the firearm owning community, we want to respect their autonomy in making decisions. That's why with the WAVE website, we've been, I think, very open to having, and as Gabby alluded to, inviting the firearm owning community into the conversation. I'm not an expert on firearms. I'm not going to pretend to be an expert on firearms, but I'd love to partner with someone who does know firearms so that we can be culturally sensitive and use the right terminology to convey the message that we want to convey. So I think when you don't know, pair up with someone who does. But in those moments when you're really concerned about safety, having the right language is going to keep you from acting, then err on the side of maybe saying a slightly wrong thing, but being open to correction from that. But I'm curious if Marianne and Gabby have other kind of suggestions in that space as well.
Yeah, I'd love to hear from you both. That'd be great.
Yeah, thank you, Stephanie. That's really helpful. I just want to say that we're helping clinicians have these conversations as well. I too am not an expert in firearms by any stretch of the imagination. And when you speak to clinicians who are, they have a different language, they have a different confidence about how they speak about this. I know the VA is coming out with some virtual training of actually how to hold a firearm to give people some confidence in this. But I think it's not just family members, it's clinicians as well who can benefit from being more comfortable with these conversations.
Thank you, Marianne. Gabby, any thoughts?
No, I think you pretty much covered. One thing to add is just that sometimes there is an idea that if you ask about suicide, you might be making someone worse or putting the idea in their minds, and that's one thing that we know is not the case. And so, as Stephanie mentioned, just reaching out and asking the question, even if it's not perfect, is kind of the way to go.
Yeah, thank you all for that. I really appreciate it. Looks like Mari Farinacci mentioned about county level data. This is a great question. We're hoping at the foundation to have a lot of information on this broken down in the coming months. So stay tuned for that. It's a really great question. We're running a little low on time. Just kind of throw a few lightning round questions everyone's way. So when I was in the service, I remember someone asked our base commander if he could do one thing to prevent premature deaths for Marines on the base. He said he'd ban motorcycles. And I remember this. I was a motorcycle rider. We were all reckless. We were all 10 foot tall and bulletproof. We just served in Iraq or Afghanistan. And it was a real issue. And it's not what I would have assumed. Similarly, I asked the VA hospital director, what's the one thing that you would, kind of, if you could do anything here, what's a big need? And they mentioned hire more police officers for safety reasons, and also was not the answer I was expecting. So Gabby, we'll start with you, but ask everyone if there was one thing that you could do to really reduce veteran suicide. What's something that you would like to see done?
I'm gonna choose a really huge one, which is
Please, I
not
love it.
one thing. But just to point to kind of like the importance of the broader socio-political context here. And so we're doing a lot to address suicide in particular and veteran suicide in particular, but just thinking about some of the bigger questions, just like dealing with unemployment, housing insecurity, sort of access to mental health care. I would highlight that specifically for, you know, within VA, outside of VA, veterans, non-veterans, I think that is kind of one huge issue that we need to tackle as a country.
Thank you. Marianne, any thoughts? If you could change one thing.
Yeah, I mean, I wouldn't change it. I think I would just keep working with the 988. I think the crisis line and having support 24/7 that's available. I guess getting it out there and making sure everyone knows that that resource is available. It's available for veterans. You just press 1, and family members can also use that same crisis line. And so just making sure everybody knows that that is a resource available.
Thank you. Stephanie?
So I'm going to take a different tact, and I'd say standing up suicide mortality review committees at the local level. I think it was Mike's point about how New York City suicides look different than the rest of the state. I think for communities, suicide solutions are sometimes local, not broad, and the ability for communities to pull together people from different sectors to take a deep dive on the numbers and understand what contexts are occurring that might be contributing to suicides in local communities, and then coming up with localized solutions to address that. I think we could definitely see some significant changes if communities and folks could come together around that.
Absolutely. And for me, I always feel like VA healthcare for every veteran. I feel like that would really open a lot of doors to resources that wouldn't be accessible otherwise for folks that might not have resources. And I say that because there's so many folks that just aren't connected to VA. So I'm wondering, last question for everyone, Stephanie, we'll stick with you for now. What is something that non-VA health providers could be doing more of, since we know a lot of veterans are not seeking care at VA because of eligibility or other reasons?
I think it starts with a question for providers to ask. Did you ever serve? It starts with that, and then I think for providers to really take the initiative to become more culturally sensitive to the needs of veterans, understand resources that are available to them in terms of training, but also partnering with VA. If you have a veteran who's coming to you from care, there are a host of resources that are available to you as that provider, including the suicide risk management consultation program. If you're a provider in the community who is treating a veteran who is at risk for suicide, it's a free consultation service. If you have any questions regarding suicide risk, that's something that's open to you.
Thank you. Marianne, any thoughts?
Yeah, just to know that the Compact Act, which is out there, which includes veterans are eligible for care outside in the community for acute suicidal crises. They can go and for emergent care at no cost, and they can also have up to 30 days of outpatient care. 30 days inpatient and 90 days outpatient care for suicide, to know that those resources for veterans in the community are available as well.
Yeah, great point. I think the latest numbers are 50,000 vets have taken advantage of that. Would love to see that. Hopefully the need's not there, but would love to see that taken advantage of more. Gabby, one last thing.
Yeah, I would say also, what was mentioned before of like increasing comfort with asking about firearms, medications, drugs that can potentially be used for overdose, just having more open conversations about suicide risk and about the potential contributions of all of these factors that are just safety factors, just like we ask about other things like seatbelts and whatnot, to make that part of the conversation as well.
Exactly. Thank you so much. We are unfortunately out of time. And we'll have to wrap things up here. But Dr. Gamble, Dr. Goodman, Dr. Kazanoff, I truly can't thank you enough for joining us today. I thoroughly enjoyed this conversation and would love to keep it going, but I hope everyone in the audience found this discussion as insightful and as informative as I have. I'd like to quickly give a shout out to my colleagues, Erica and Maureen on our communications team, for all the behind the scenes work to make this happen. Is greatly appreciated. If you're still on Twitter, be sure to follow us at NYH Foundation and myself at Classic Decoy. Also, sign up for our newsletter on our website if you haven't already for more details about future events and other updates. Thanks again to our amazing guests for the incredible work that they do for participating in this important conversation with us this morning. And thank you all for joining. Hope everyone has a wonderful rest of their day.